Hello and welcome to tonight's episode of Newsnight. Nigeria's health sector is in the grip of a protracted strike action embarked upon by the Nigerian Association of Resident Doctors. For almost a month now, hospitals across the country have been thrown into disarray. Patients are stranded and critical services disrupted. At the heart of the crisis are 11 demands, ranging from unpaid salaries and hazard allowances to residency training funds and hospital infrastructure. The federal government insists that progress is being made, but resident doctors say little has changed. So what are the real issues at stake? Why has Nigeria's health sector been described as a national emergency? And what does this strike mean for the future of healthcare in our country? Tonight, we sit down with the president of the Nigerian Association of Resident Doctors, Dr. Mohammed Suleiman, to unpack the strike, the state of Nigeria's health system, and the way forward. Thank you for being here, Doctor.
Thank you very much for having me.
I would like us to go straight from the top, and I think that it will help if you help us understand what your organization, tell us about the organization.
Thank you very much. The Nigerian Association of Resident Doctors is a group of, is a body, an association for a group of doctors ranging from house officers, medical officers, resident doctors including registrars, senior registrars 2, senior registrars 1, who are in institutions that offer residency training. And this includes federal tertiary institutions. There are a lot of state tertiary institutions in Nigeria that offer residency training. And we have a few private tertiary health institutions that are also affiliated and are members of our association. So that is the bracket from house officers up to senior registrars and senior medical officers 1. These are members of the Nigerian Association of Resident Doctors.
But when you say resident doctors, you're basically saying these are doctors in training.
These are doctors in training.
Okay.
So one form of training or the other, that eventually you come out at the other end as a specialist.
Okay. Yes. I would like you to go straight. You know, one of the issues right now is that the association is on the front burner.
Yes.
And that's because of a strike action.
Yes.
Now, can you help viewers understand what makes this unique? Because I know NARD has been in the forefront once or twice. You want to, there's something wants to be done, or whether there's a threat of a strike or there's a strike. But what makes this particular industrial action unique?
Thank you very much for that. In the last few years, specifically, let's say 3 years, we have always engaged. These are not new issues. The issues we're talking about today have been there for quite some time. And when I go into each one of them, you will even hear how long these issues have been there. We will sit down with government, have a conversation, agree on how we'll move forward on some of these things. A few weeks, months down the line, and you're back to square one. Issues have been left to continue to decay. For instance, in the middle of September, we had an ultimatum that eventually led to conversations, and a 2 weeks ultimatum was given to government that ended at the AGM that brought my current leadership into office. And at that AGM, the association looked at it that you can't come in as a new president and then start strike. And we gave a 30-day period to run from pillar to post to explain these issues. Unfortunately, the 30-day elapsed, nothing happened. And then the National Executive Council called us for a review and further extended by giving another 1 week before we declared the strike. So that's about 7-8 weeks of ultimatum upon ultimatum, even before the strike started. And I can tell you, I've had 2 predecessors who have engaged in diplomacy. The last time NARD was on such a strike was probably in 2022 or 2023.
No, 2022, I think.
Yes. Now, what are the issues involved? 10, 12 years ago, at the federal level, we had about 16,000 resident doctors. At the state level, the state tertiary health institutions that offer residency training, we had about maybe 6,000 to 7,000 resident doctors. At the private tertiary health institution level, maybe 1,000 or even more than that. Today, we have just about 11,000 across the entire country. Maybe 8,000 to 9,000 at the federal level, 1,500 from the state level, and maybe just 200, 300 at the private tertiary health institution level. Why are people leaving? So the top most paramount issue is actually excess workload and burnout. What do I mean by that? If 10 years ago or 20 years ago, Nigeria's population is 220 million, public health estimates today put it closer to 260, 280 million as a population of this country. That means 10 years ago, 10 doctors will probably see 1,000 patients in a month. Now, because that number has collapsed, you have 3-4 doctors seeing 2,000-3,000 patients in a month. And to compound that, because the number is less, our people take calls every day. What do I mean by that? You come to work 8 o'clock in the morning, you work your normal civil service till 4, you're on call. 4 to 8 a.m. the next morning, you're in the hospital working. You do another 8 to 4 of normal civil service, you're on call again. 4 o'clock that evening till 8 the next morning. And this continues. And let me give you specific examples. In the orthopedics department of FTH Lokoja, Dr. Victor Audu and Dr. Yomi were on call in October. Yomi was on call 31 days of October. Victor Audu was on call 22 days of October. My own treasurer is the only senior registrar in his own hospital in the plastic surgery unit, which means since February, he has been on call alone like that. What does that equate to? You give as a physician over 100 hours every week. You give as a surgeon over 120 hours every week. It will burn you out. It is excess workload. You get tired, you get frustrated, and you are required to take critical, important decisions on complex cases every day, every single time. You're bound to make mistakes. Is it really fair to ask Nigerians to continue to be reviewed by these burned out, tired patients, doctors, I mean? Now, add that this is one problem, which is why NARD is demanding that after 24 hours of call, a doctor must go home and rest before you continue working.
When you say 24 hours of call, so after he does the normal shift,
yes,
you now count if he has another.
If you come to work 8 in the morning,
yes,
you work till 4.
Yes.
You work that 4 till the next morning as your call, 8 a.m.
Yes.
You now do your normal civil service till 4. You should go home because that's 32 hours. You should go home and rest.
Okay.
Rest so that your decision-making ability is not hampered over time.
Wait, are you saying right now we don't have a sort of shift?
No. Doctors don't take shifts. Doctors take calls. And the call period is when it starts, you're in the hospital. You're not going anywhere until the call finishes. For instance,
when I mean shift, I mean if I have, you have a group of doctors that are in the hospital, and so some are on call, some are not on call.
So how it works is, let me give you a practical example.
Yes.
I am in the pulmonology unit of internal medicine department in FTH, Katsina.
Yeah.
So when it is our own call, I am the senior registrar that will remain and take charge of that call until the call period is over. If I'm lucky, I have one registrar and one house officer to assist me on that call. Now, what I'm saying is a lot of the units in a lot of hospitals in this country don't even have the luxury of 2-3 people being on call at the same time. It's usually just one person. And calls are stratified: first on call, house officers; second on call, registrars, medical officers; third on call, senior registrars, senior medical officers; and then fourth on call, consultants. It is usually resident doctors that are the backbone of giving out these services during those call periods. We don't wish Nigerians will come to a call and then you have to call a consultant to be on ground. It means the case must have really been a bad one for you to see that. So that is the workload that is really put on residents.
And that is a major issue.
It's a major issue. It's a major issue. Now, other things have added to that. For instance, this year, the Office of the Head of Service came out with waivers that said the entry level for doctors into civil service is no longer COMMES 3. COMMES is the salary structure for doctors. Now, COMMES 3 was agreed upon more than 12 years ago. In 2014, 2013, it was agreed that that would be the entry level for doctors into civil service. Now, this year, they said COMMES 2. What that means is that your salary falls immediately at that entry level by 150,000 naira. And there are circulars even signed by previous head of services allowing this readjustment of this entry level. We are saying with all this excess workload, you're now looking at ways to bring down the salary of doctors. Then in FTH Lokoja, union leaders took up some of these problems, these manpower shortages, problems here and there, and they protested it. And then they received queries. From those queries, panels were set up, albeit with questionable decisions. And then they were eventually terminated, 5 of them, unjustly. We're also looking at, there's something called the professional allowance table. In the COMMES structure, there's a basic salary, and then there are professional allowances. In 2014, we agreed with government, whenever you adjust minimum wage, it affects basic salary, it also affects allowances. That makes sense. Since 2019, 7 years ago, Whenever there's a minimum wage adjustment, it doesn't affect the basic salary, the allowances of doctors. It only affects the basic salary.
And this cuts across doctors, not only resident
doctors. It
doctors.
cuts across all doctors. In fact, the cumulative effect of that is that that allowance table means you go home with just about 45 to 50 or even 60% at best of your own allowances that you are entitled to. Early this year, in fact, several years ago, we have been engaging government on it. We wrote early this year. Government sat down, looked at it, and added a meager 1.7%, which means if you're going home with 45% of your allowances, they made it 46.7%, and we rejected it.
And other people got what?
It was put across board for everyone, so we all rejected it.
Okay.
And then eventually, we sat down, we did a cross-section of what the table would look like, and the proper table was done. Now release that table. Just release it. You'll be hearing excuses here and there.
Who is to release it?
Well, the Salaries and Wages Commission should release it. And to be fair to them, I think they've done their due diligence. But the parent ministry, Federal Ministry of Health, also ought to be on board with that release. And in the negotiations during this strike, we came to a point where we were informed in a few days that table will come. That was probably 10 days ago that we were talking about those few days that table would come. And there's still no headway as to when that table will come. If you look at other issues, we've had medical officers who are members of NARD that have been promoted in the civil service of this country as far back as 2018, 2019, 2020, 2021, and they've not gotten their promotion arrears. When we complain, we'll be told it's a service-wide problem. Now, during this industrial action, we sat down. The Minister of Finance was there. He was very happy to receive the quantum of what the money will all be like, and he promised us he will give us a payment plan. Of course, we had considered that if Chief Wale Odun, the Honorable Minister of Finance, Coordinating Minister for Economy, gives you his word, at least you should go to the bank with it. But it behooves the parent ministry, our own parent ministry, to compile this list, submit it to him. That submission, I am not sure has been done as at this moment that we're talking. It is what we're asking for. Just submit it to Ministry of Finance or the Budget Office. Let them give us a payment plan. We can go back and tell our members, guys, they've done the compilation. This is the amount. They said they will pay by X, Y, Z time. I think that is a fair deal.
You know, from what you're saying, there is a lot, and you've tried. I'm trying not to let's use all the time to pull out the issues again. But what is the present situation now? Because the last I heard, government is saying they've done some, and they want you to show good faith, and it appears you are standing that you've not seen anything. What is the situation on ground? So
out of our 19 points,
yes,
government has released payments for the 25-35% arrears, which is an arrears that has lingered, is a salary arrears that has lingered for about 2 years. Now, about 60% of our members have gotten. We are to engage with the IPPIS and see the remitter report generated to see failed payments, omissions that is responsible for the other 40% not getting. Okay. Now, that was what we agreed. Up until now, the remitter report is not been made available for us to look at what the issues are. The accoutrement allowance, I think it was even yesterday that some of these payments were even finalized for some of our members. Others got a few days, I think even last week. Now, some got yesterday. Now, let's even assume that this takes care of these 2 items. You still have another 17. In those 17, I've mentioned like 5 or 6 of them. Okay. For the professional allowance table, we agreed it will come in a few days. And then when we came to sign an MOU, we were told it can't come earlier than 2 weeks. So we're expected to wait for more than 2 weeks. I mean, no specific date was proposed. On the issue of the entry level into civil service, it was the head of service that will make that clarification so that everyone goes back to that commissary and will continue. We've been doing that for 12 years. And what was the response? That a letter will be written to the head of service. We were asked to do a follow-up in the head of service office. And when we went there, the response was supposed to come on Friday. As at that Friday, the head of service was not even aware that there is a need for them to clarify the issue. Whether a letter has been written or not, but this is the information coming from the office of the head of service. When you look at, let's say, the arrears I just told you, yes, compilation has not even been completed. What does it take for a chief executive to tell you this is the quantum for the amount for this salary arrears? I mean, OHS, THC, Ile-Ife is there. FMC Owo is there. Federal University of Health Science, Otupo is there. UITH Ilorin is there. UUTH Uyo is there. Some other hospitals. Benue State University Hospital is there. I agree. State institutions are not under the purview of the federal government. But what does it take? Like in Benue State University Hospital, they have about 20 months worth of arrears, salary arrears. You know, so these are the issues we've been grappling on. Why is it urgent now? Because the conditions under which doctors work now is very, very tasking. You don't want a frustrated, under-remunerated, underappreciated doctor. You know, when you hear things like doctors' patriotism being called into question, when you hear things like doctors being described as taking the militant approach to doing things, we're honorable people. We've been trained to have empathy. Over time, that empathy became sympathy. Over time, that sympathy for our patients and the Nigerian situation became pity. The system now automatically demands that you drain your blood into service. Now, we've had colleagues who have died. A few days ago, a colleague died from a comorbidity. He's even too young to have those kind of comorbidities, but the stress of the job is there. Even if it is not a primary factor, it is a contributing factor. Would we want, as Nigerians, for our populace to be consulted by these type of doctors, doctors who are very, very tired, very, very frustrated? Now, I can see the narrative making it seem as if we are just asking for money. Now, I've described issues to you now. Is it only money? Even from this, our conversation. There's a special pension program being talked about with government. And our parent body, the NMA, engaged with government. And about 3 months ago, a high-level body was set up under the guidance, the chairmanship of the Office of the Head of Service, together with the Director General of the PENCOM. And that committee sat down and had an inaugural meeting. From that inaugural meeting, everything stopped. This is 3 months down the line. And what are we even asking for? We're not saying that committee should immediately finish its work and then send a report. No, we're saying reconvoke that committee. 3 months is too long a time for you to just allow it to crash. You know, we're asking that the Office of the Head of Service and the DG PENCOM reconvoke and let them continue sitting. In fact, NARD is not even a member. But you know, we'll eventually exit this program as consultants. Eventually, we'll get there. It's directly affecting us. Another issue is the collective bargaining agreement. And I like to talk a bit about this. It is a platform where the government sits down with associations and agree on what remunerations will look like. Last time something like that happened for doctors in this country is 2014. That's the last time and government gave us a plan of 3 weeks to do a CBA 3 months ago, almost 4 months ago. And unfortunately, after a week or two, everything stopped, everything stalled. And some reasons have been given as to why it stalled. Some reasons are being given as to why it cannot even finish in 3 weeks. But I can confirm to you right now, the CBA is not going on. So doctors don't even know what platform will be used to even adjust the salaries. Why is the CBA relevant? That professional allowance table that I talked to you, that we have been shortchanged in our allowances for the past 7 years, is supposed to bring us back to the basic level that we ought to be, according to the law in Nigeria. It is that basic level that you go into the CBA to negotiate and see whether government can afford 1 naira, 2 naira on top of your salary. Now, if we go into the CBA like this now, you're already on a negative of that professional allowance. You now go and start negotiating from a negative platform. Is it fair? So this strike is not even asking for a salary increment. It's just saying continue with the process. Continue with the process. Don't allow it to stall. It cannot just stop and there are no meetings for 3 months, 4 months. Of course, naturally, doctors are scientists. They will look at it that someone is sitting somewhere and frustrating this. Moreover, why are allowances dragging? Why are salary areas dragging? Now, I put this to you. Do you know any governor, any senator, any member House of Reps, any permanent secretary, any minister that has a 2 years arrears, not talk of a 7-year arrears? Do you know that? And then we are described as being essential workers, and then it looks as if you're just coming out to be militant, to look for trouble, to cause the disruptions. But these are germane, valid issues.
You also raise issues as regards the state of infrastructure, that there were things about in some places, because I don't want to believe it's everywhere, that even where doctors on call can stay is a problem.
In fact, hospitals have lost accreditation for residency training because call rooms for doctors and house officers are not up to standard, are not up to par. People have to share some. Now, even leave call rooms for doctors. Let's even talk about the infrastructure in the hospitals. Power is now a problem. Electricity is now a problem. These chief executives are drowning in depths of electricity. At the end of the month, you see 60 million, 100 million, 150 million. Where will they get the money to pay? Which means they will have to stay a few weeks, a few months without power. How does that affect patient care? If you have a surgery, you have to wait for when the hospital will on its generator to target that time, which means if the time has lapsed for the generator to be working and emergencies come, is either you find a way to tarry that emergency until a time power will be available. Otherwise, you use candles and torchlights in our theaters in present-day Nigeria. Or you go to ward rounds and you see beds broken. You know, or an emergency comes in, Yes, we're bringing CT scans, MRI machines, we're building cancer centers. I am so proud to be attached to those kind of developments. But then an emergency comes, and then you as a doctor, you'll have to look for where you'll get cannula, where you'll get syringes, needles, IV giving sets, IV flutes to give that patient. Sometimes you buy them yourself. You know, so what are we really?
The picture you are painting
really
is a very scary one, and you know, when patients come to a hospital, they actually come in because they're in need. So that may not be the best time to actually do a review or understand how the hospital works. And you people are the ones that are in that place.
In
so
the
your perspective is very clear. What does this say to our health system right now?
Well, I think those who are saddled with the responsibility of policy making in the health sector have all the qualifications therein. I mean, this is Nigeria. We all read our books. And I think they probably go to sit down with the best of intentions. But I will implore them to really come to the front line. Come and be with me during the call and see how patients insult us. Not because we are late to review them, but because a cannula is not available, a gauze is not there, an artery holding forceps is not available for you to suture something. Nigerians react to these things. I'm happy hospitals are springing. I'm happy we are.
You mean springing up in the private sector? Or what do you, when you say
no, I think in the last couple of years, you would agree with me, government has opened up new federal tertiary hospitals, FMCs, and then mono centers like orthopedic centers, neuropsychiatry hospitals, all across the place. There are just two problems with that. One is, where is the workforce to work there? The federal government has waivers right now to employ over 20,000 healthcare workers. They are not there.
They're not available.
Even if they're there, okay, let me tell you the reality on ground. MSF recently called for an interview. I think they were looking for about 100 doctors. They got 100 doctors.
MSF being?
Medicine Sans Francois, I think is an NGO in some of the northern states. For what they pay, they had, and they only ask you to give them 208 hours in a month, as against my 450 hours that I give in a month. You know, whoever gets that MSF will be able to pay my salary at the federal level, my own salary at Commerce 5 times 2, and still have enough to relax in the Nigerian economy for a whole month. You know, so when you call for that, do you really think doctors or the health workers that are still staying back in Nigeria in their little numbers will pick it up? Especially when you have bureaucracies that delays this process. Somebody applies to get a job in January, as at October, November, you have not called him to pick up that employment. By the time you're calling him in December, he won't wait from January to December for you to call him. He would have probably gotten hooked somewhere, or, which is most probably the case, has left the country.
So let me get this clear now, because I was about to ask. I do know we're having more universities, and I do know medicine is still a very well sought for course in universities. Yes. So the problem isn't that we're not churning out enough graduates.
It is not.
What then is the gap?
In fact, the federal government has recently, and I must commend the Minister for Education, Dr. Tunja Lausa. I think he's doing a good job. I think they are looking at doubling admission and graduation quotas for doctors, dentists, nurses, and all the other health professionals. I think it's a good one. You may have your criticism of it, but that is government taking initiative. But how do you retain them when you produce them? Are you going to go to the National Assembly and tell the National Assembly, make laws so that we bond them for 5 years, by fire, by force, they must stay?
But you know that has come up.
Yes, it has. and it's quite unfortunate in 2025 we're talking about that. But the reality is 2 things or 3 things at most keeps safe regulated work hours, remuneration, and career advancement, academic progression. If you make that conducive, who will leave Nigeria? Nobody will. And if you check whatever it is we're talking about in these our industrial action, it has to do with 1 or 2 or all 3 of these 3 things. You know, so it's not rocket science. And I think if we put our heads together, I think we can solve the problem together. I'm sure I've started sounding like a policymaker because I am heading an association that year in, year out, every meeting, we call out these issues. We've been talking about these issues from the time, even before I graduated from medical school. This is more than 15 years. NARD has been saying, leaders that were in NARD 10, 20 years ago will still be telling you, this person is sounding like when we were in NARD. We're still saying the same thing. The problem is still there. Some of them will say, we are getting it a bit better now. I don't know why. We are still in the system. This is my 5th year as a resident. I started in 2020. And it's still the same problem everyone is talking about. I would hope those that are policymakers, this is not to say they have failed. And I think they need to understand that the conversations need to be as honest and as frank and as open as possible.
I'm interested in understanding from what you're saying. Now, if you look at the point, because I'm happy you mentioned when you were talking about a lot of cancer center. The ministry has been coming out to say a lot within the last 2 years. This administration has come, they've done a lot in the health sector. And I couldn't help but look at it that it looks like, from what you're saying, the position on ground contradicts what their achievement, what they're listing out as achievements.
Let's look at it this way. For whatever policy you want to bring, for whatever thing you want to do in the health sector, for public health, for the sake of Nigerians, workforce and infrastructure must match.
Okay.
So if you upscale the infrastructure and the workforce is left behind, not motivated, not well compensated, not protected, I mean, the infrastructure will keep on going up with nobody to dish it out in form of services.
So there's a concentration on infrastructure?
I honestly think so. I honestly think there's a concentration on infrastructure because FMCs, in Adamawa, for instance, 2 FMCs have been approved. 1 has been approved in Kumo. I know in Borno State, an orthopedics hospital has been approved. Same in Taraba State. When you go around the country, new hospitals are springing up. Where is the manpower to man it? If you go ahead and put CT scans in all of them, fine, excellent, we're happy. You know, it gives us tools to work. Who then goes to deliver those services? Now, 20 years ago, we had 25,000 resident doctors, probably over 10,000 consultants. I'm not holding forth for MD-CAN, but I think consultants in Nigeria now in federal hospitals, maybe will be around 6,000-7,000. You know, and then you have residents just about 8,000-9,000. Now, juxtapose that against 250 million as our population. You know, that means you're talking about 1 doctor to over 10,000 Nigerians. Is not sustainable. Something has to give, something has to be done. As we are looking at policies to improve infrastructure, we must also look at how the workforce can be improved, which means we need to start retaining. What is happening now? Look, we produce the best doctors. And you have to give government credit for that. They made our hospitals the way they are to train the excellent doctors that we have. Wherever you go in this world and you're called a Nigerian doctor, the respect is different. But we produce them and then we bleed them out. And then after we bleed them out, we turn around and call them not patriotic.
Doctor, help me here, because maybe it's me not getting the mark. We do know that a lot of graduates, we still have a lot of graduates as medical students. And they're supposed to immediately come into your association because residency is still part of the training.
Yes.
So I'm wondering how we're having the shortfall.
It's a straight line map. Okay, look at it this way. If all the residents who are practicing in US, the health sector of US today, and the NHS in UK today pull out of those 2 healthcare systems, those healthcare systems will collapse.
True.
Which means there's something they have that is attracting our people.
No, help me, because I'm just trying to be clear here.
Yeah.
When you finish university as a graduate, as a doctor, you still have to do
your housemanship. You still have to do your housemanship, do your NYSC, then pass your primaries and then start residency or pick up an employment somewhere as a medical officer.
Yes.
So most of the young doctors that are on ground now use that as a stopgap measure to raise a few funds to Japa.
So between housemanship, NYSC,
starting your MO job or your residency, you have gathered enough resources, you have passed the necessary licensing exams in those countries, and you have left.
Okay.
That is where the gap is being created. We are producing them, and then we are bleeding them. For us in the association, we think when you give competitive pay, it doesn't have to rise to the level of UK. What we mean by competitive is a survivable wage. You know, work must work for the worker, not just the government.
From your perspective, if we were to rescue this health sector in a way that will help you as the practitioner and the Nigerian public as the patient, what would you be asking for?
Well, I think first of all, everything has to be patient-centered, which means you take care of infrastructure, you take care of workforce. There's the countries that have done well in terms of their healthcare service delivery. The general administration of the health sector is given a special priority and is not marked under rules that govern every other person in civil service. I know this is a controversial point. Everyone will look at it that doctors want a special system for themselves. No. Hospitals don't run as Ministry of Finance or as Ministry of Works.
As a normal civil
service. They don't work that way. One thing collapses in the hospital, you know it has ripple effect on people's lives. I think that reform is required, and I think we need to look at it from that perspective. Let me give you an instance. When a senior registrar passes exams to become a senior registrar, he's upgraded. That is done under the IPPIS system. Now, IPPIS found some corruption within their system, and they are sorting it out, and kudos to them, and I think it's a good step to take. But that now means that they had to take away the power of that upgrade from MDAs back to Abuja. Which means if you pass exam, someone has to leave your hospital to bring your list to Abuja for you to be upgraded. And then imagine bombarding Abuja with all the numbers of people. And Nigerians are brilliant. People are passing these exams. And then you bombard them with all of that. One person in Abuja will sit down and is overflooded with that. And there's a delay, there's a gap. Now we have doctors over a year, they've not been upgraded. No arrears, no allowances. We have a special need that requires special policies, special reforms that will create an enabling working environment. If you go to the UK and your supervisor tells you to work beyond 48 hours in a week, he has to justify it. He has to compensate you, or he has to give you leave commensurate with the extra time that you pick. In Nigeria, we're giving 120 hours in a week, over 400 hours in a month. Then you're asking for it to be capped, and you're termed a militant. So it doesn't, that reform is needed. We may be young, we don't know all of what is going on out there, but on the table of conversation, we also need to be there. That voice needs to be heard.
Okay, so that's one way of helping out.
Yes.
But if you were to look at the way we run our hospitals, is it viable?
Well, it is not for me to say now, because I think these hospitals have worked for so long. In the 70s and 80s, if you work in UCH for 1 month and you carry that letter that you have worked in UCH, Ibadan, and you go to UK, that alone gets you a job in UK. What were we doing differently then that we're not doing now? I think it's just about introspection. Whatever system we adopt, it should just be patient-centered. Let me not sit on national television and claim to know better than policymakers, but the reality is something has to be done about it.
Okay, now I'm looking at the demands, and you've painted a very,
I would call it a realistic picture.
Realistic picture. I think in one time you said you described Nigeria's health sector as a national emergency.
Yes.
That something needs to be done.
Yes.
But looking at your demands, your 19 demands,
yes.
I'm asking, my understanding is that usually when you come to the negotiation table, there is allowance that something can give, something can take.
Yes.
What is the minimal you are asking from government that you will not leave the table unless this is done?
So before we started the strike, the National Executive Council said all the 19 demands. After our conciliation, and we were to sign an MOU, dates were shifted, we didn't sign, and we reported back to the National Executive Council. National Executive Council said, take care of the entry-level problem. Take it back to Comments 3, Step 3. Take care of the promotion arrears problem. Take care of the salary arrears problems. Take care of the professional allowance table. Then reinstate the Lokoja 5. Solve the membership certificate problem. Which is the 7th one, I can't remember immediately. And then NEC said, we can move forward. Now, NEC coming down from 19 to 7 is a huge leap, is a huge leap in the right direction.
And as you said, some of them are
one paper.
One paper.
The professional allowance table, I was telling someone that if I was on the side of government, I would say release this professional allowance table, but I will implement it 1st of January 2026, when I know that I have the money to pay for it in the budget, if that is what the problem is. For the allowances, since the coordinating minister for the economy, Chief Wale Edun, has made that pledge, pack everything and submit it on his table so that you now point the finger at, Shebi, you said, so those are some of the, but I don't know, letters are not moving as they should, people are not taking action as they should, and then they turn around to blame residents as being insensitive. It is the sad part of it that resident doctors are seen as insensitive. I can't remember when last it is this bad for resident doctors. And I'm not afraid of saying it anywhere. If you feel it is unfair for resident doctors to see it, resident doctors across this country, by mandate of the National Executive Council, even by mandate of the annual general meeting, also feel it is unfair for us to say 19, then come back from 19 to 7, and then we're still dragging our feet. I hope we'll have a headway very soon. In fact, what we're hearing is that perhaps some punitive things will fly across to resident doctors. I hope it doesn't happen, because that will worsen the situation. The NEC already has a standing order on what to do whenever anything punitive comes along against resident doctors. I hope moving on from here, we'll be able to move ahead. And I want to take this opportunity to call on Mr. President of the country. To us, it seems as if people who come around him don't tell him the actual picture. We hope he will take time to listen to us. We're not asking for too much. We know he has a lot on his table, but we know 5 minutes of his time can solve our problem. We're appealing to him to beam a searchlight on the welfare of resident doctors, and by extension, the welfare of the entire health sector. You know, with his grace, I think he can solve a lot. I made this appeal a few weeks back, and I said, professionals that come to you, that talk to you as professionals, Mr. President, some of them are politicians, and they have interests. I am not a politician. I am a professional who works in the hospital, and I'm telling you, this is what we are going through. Mr. President, come to the aid of resident doctors. Let me end by saying I appreciate the Honorable Minister of Labor, the Chief Conciliator of the country. I think he has a genuine passion to solve our problems. The Honorable Minister of State for Health has been in some of those meetings, and I see he's really doing his own bit to make sure he solves the problem. The Honorable Minister of Finance and the Coordinating Minister for the Economy, I think he has made it clear. Give me the financial things, I will sort it out. And it is the rest of us that are on the negotiation table that have not done our part to give him that. I must commend him together with the Honorable Minister of State for Finance. The Senate Committee on Health, the Chair of Senate Committee on Health, Senator Epalibo Banigo, I think she has been putting in her own efforts to see that these are addressed. The House of Reps Committee Chair on healthcare services and tertiary health institutions, they've done their part, especially with respect to the Lokoja issue and the rest of our demands, basically. Now, it is not them, it is not these people that will implement it. It is the federal government as a team that will implement this. So I am here thanking them for their genuineness in trying to solve the problem. It is not enough to say, these are genuine, we should solve them. It is not enough to even agree on how to solve them. What must be done is to solve them. We must not just write on a paper. No, we must put action to it. So that tomorrow, if we suspend this strike, I don't have to come back to this issue. The National Executive Council will move on to other things that probably are even away from this. I don't think it helps to come to the media and be putting out things that are false, things that are blatantly false. I don't think it's right coming to the media to say 50 billion, so they should come back to work. That 50 billion did not come to resident doctors. You know, probably it's got across everywhere. You know, it's even an admission of guilt that you're owing that kind of an arrears, you know, over 2, 3, 4 years to the healthcare workforce. You know, so I really hope people will listen.
But you're also raising, because it's, if all these people you've thanked, beyond solving this problem, it means there is need to review the whole health sector and ensure, because you mentioned earlier the issue of how it's the structure.
Yeah.
So beyond solving this issue,
beyond solving this issue, we need a national rethink on how our healthcare system delivers healthcare services to our people. We really do. To assume we don't is just window dressing the issue. I have practiced as a medical officer for about 10 years. I've been a second on call for about 10 years. And I've practiced as a resident for 5 years now. I am not the most experienced, but at least I've had my fair share of interacting with patients. And I'm a Nigerian. We all know the reality of what Nigeria is. Do we have the worst system in the world? Certainly not. Can we do better? Absolutely.
Let me take you up on the issue, because I remember some years before, one of the things that was done was to bring in this NHIA, now NHI, was NHIS
Yes.
then,
Yes.
now NHIA. It was supposed to also help with the running of this hospital, making funds, if not at least directly to welfare, but for the running of hospital and for the good of the patient. From your perspective, how has that helped?
Well, you are hitting the nail on the head. And I think the NHI can do a whole lot better for our system. The world over, healthcare is not cheap. So everyone has turned to health insurance.
Mm-hmm.
Are we doing what we are supposed to do? What is the health insurance cover today in Nigeria by population? What is even the health insurance cover by the educated population? So there is a lot of standards there that we're not meeting. It's not part of NARD's demand.
Yeah, no, I'm asking you as a practitioner.
Can it do better for our hospitals? Mm-hmm. Certainly it will. Look at private hospitals, and let me not mention names. Look at private hospitals. They have an insurance system. They work with these HMOs. They have an effective way of ensuring these services are delivered. What are they doing differently that we can't do in the
And some of them are still using the NHIA.
Yes, they are. In the private sector.
In the private sector?
They are. And they found a way to make it work in the private sector.
What would you, because a lot of, usually the saying goes that when two elephants fight, is the people that you serve that are getting the brunt of this confrontation are wondering when you will get back to work. So I don't know what, from where you are sitting, when it looks like this can be resolved. What's the latest you've heard from government that can give you something to go home with that you can tell Nigerians?
Well, you mentioned when two elephants fight. From what I described to you about what resident doctors are going through, are we really elephants? Are we not the grass too being trampled upon by the bigger elephant? Anyway, that's just a rhetorical thing. For the National Executive Council, it had made it very clear. The 19 is now 7+1. And let us have a conversation in that regards. I'm hearing something is working on the professional allowance table. I'm hearing efforts are being made to get across to the head of service to clear the entry-level issue. I'm hearing the compilation that we've been complaining about are being finalized for onward transmission to the Minister of Finance. I hope these are true. By Monday, I hope to run around, because that is what you do when you're on strike. I hope to run around from one agency of government to the other to see that, yes, this is true, to see the evidences. And then hopefully someone will sit down officially, put it on paper, and we sign. Once that is done, and we're able to verify that these things are done, it's not difficult calling the National Executive Council. I mean, people want to go back to work. Let's not come out here and make it seem as if residents are celebrating that they are on. Nobody is celebrating. Strike is a last resort. We have no other option of bringing things to the fore for people to hear us. I'm happy we're being heard. Even if it is to come and say they are not patriotic, they are choosing militants, but at least we're being heard. And Nigerians, to a very large extent, I'm sure now have a better understanding of what these issues are. I'm calling on Nigerians to continue to call out government, call out those responsible for solving these problems. For us, once the needful is done, 19 is now 7+1, you know. That's a huge leap moving forward. And I would hope we will quickly put pen to paper, ensure that these things have been done. And I will summon the National Executive Council as they have empowered me to do.
Thank you so much. I think I would say that a lot of Nigerians will be hoping along with you that things are done and resolved as quickly as possible.
Amen.
Thank you so much.
Thank you for having me.
Pleasure. Clearly, there's still so much work to be done in Nigeria's health sector. You've heard the government's position, and you've heard directly from the president of the resident doctors. Now, we'd love to hear from you. What's your take on this crisis? Share your thoughts with us on our social media platforms and send an email to the address on your screen. Let's keep the conversation going. And if you would like to catch up on past episodes, simply head over to our YouTube channel, search for Newsnight, click on the playlist, and watch any of our previous discussions at your convenience. Thank you for spending your time with us. From all of us here, have a wonderful day.